Good morning, said Agnes. Good morning. How are you this morning? I'm blessed. I don't know about you. And good morning to our family members online. I just want to apologize and also make the announcements that our speaker is running a bit late, so she should be here in the next 5 minutes. So we'll start, I think, 9:15, 9:17, yes. Sorry about that. Okay, it's 9:17. Humble apologies again. I think we're gonna start now. Good morning again, and welcome St. Agnes family in attendance, and to everyone joining us online today. I'm so happy to see numbers today. Very grateful to have you around. This is a cancer awareness seminar today, which would be presented by Dr. Nompumelelo Pamela Ntshangase, whom I will introduce a little bit later. But before we proceed, let us pray. Gracious and loving God, we are gathered here today, this morning, in your house for this cancer awareness presentation. We thank you for this opportunity you have given us to learn more about this disease that has had so many of us and some that are close to us. Help us, O Lord, to gain as much knowledge as we can that pertains to it and to be fully equipped to deal with matters surrounding it. We pray that after this learning, we are fully equipped to pass the knowledge to our communities and to make a positive change in the livelihood of our fellow communities. In Jesus Christ, I pray. So a little bit of a short bio, without wasting too much time. Dr. Nompumelelo Pamela Ntshangase Mpanza, daughter of the kingdom under the leadership of PS M and Z Ntshangase at World Harvest Bible Church. So she's a child of God. Daughter to Dr. Lindiwe Ntshangase, wife to Zwakele Mpanza, a mother of 3, medical doctor in practice over 17 years, specialist on ONG, which is obstetrics and gynae, by profession and employed by the Department of Health. She is also an honorary lecturer at the Department of ONG at University of Kwazulu-Natal and has an interest in the prevention of medicine. She's a founder of Excellence Health Foundation, NPO, that deals with women's health in the community. And I think we are very blessed to have so much knowledge and wisdom around us. So on behalf of St. Agnes family, please allow me to welcome Dr. Ntshangase to the stage to equip us with cancer.
Good morning, everyone. Good morning. I am very, very pleased to join you today, this morning, and thank you very much for having me. I know they said 17 years of something, but I always like to say that I don't know it all. I didn't get 100% at medical school, so there's no ways I know everything. So there's always something that's, yeah. So good morning, everyone. Thank you so much, Mambali, for the invitation. And greetings to everyone, the ministry and everyone that I've had a chat with. It's nice to actually put the WhatsApp chats now and have a face behind that. So just to explain what we're going to do, I was told we've got how many hours? Okay, so that's a long time, so I'm gonna try to not be so boring, and give a lecture that's gonna be 3 hours, because otherwise we're gonna get tired. So I'm Dr. Ntshangase, I'm a gynae specialist. I haven't stopped studying yet. I'm actually starting my training in gynae oncology practice shortly, but for now, I'm just a gynae specialist. So most of my talk is taken from the years of experience that I've had and things I've learned along the way, and I'm hoping that you will learn something. We have, fortunately, 2 speakers today. There is Dr. Lubelwana, who will join me shortly, but she's busy with the rounds in Busamed right now, and when she's done, she'll be joining us for another part of this talk. So, what I'd like to know is, what do you want to know? Maybe let's start there, so that we just gauge as to exactly, are there any burning questions before we start? Just 2 or 3 burning questions? Like what you're hoping to achieve from, I don't want this to be like this Dr. Ntshangase standing there and lecturing, but I want it to be an interactive session and you're allowed to ask questions as we go along. Okay.
You heard me?
Yes. So what are the signs to look out for? Okay, we're talking about which cancer specifically? Any? Okay, good. Yes? Morning.
Thanks very much, and thanks for the invitation. I just wanted to check and also to know, we've noticed that suddenly cancer infection is increasing. Mostly, I would say not just amongst women only, but also it's spreading towards the younger generation. And I'm not saying this because I know there's a reason that it's supposed to be targeting a particular age or something. But I think what is important for me, which I would like to know, is it maybe a change in lifestyle, change in foods, or are there things that have changed so much that are now making it common, because it was once in a while before? So
Okay.
just so that in terms of our lifestyle, in terms of the kids as well, or our daughters, we can also empower them to be aware. And then my last question is, how much of the information that is going across in terms of your use of moringa powder and is true, and where to source the right information with the right information so that you are not misled? Thank you.
Okay.
Doctor, I would like to raise the following. We've all been, those of us that have daughters, had our daughters injected, vaccinated. Mine was 17, and I knew that she was not sexually active. She's just had half her cervix removed. I need to know. I'm saying to her why, and she's in Cape Town, and she said they can't give me an answer. Why it happened, even though I had the 2 vaccinations 6 months apart. Now, the chances of her ever carrying a child with half a cervix.
Okay.
Oh, which
I
vaccine?
assume it's HPV vaccination. Okay. Yeah. I'll explain that. Yeah, okay. So, okay. Right. I'm hoping that we'll cover most of those questions. And obviously, as we go along, if you've got more questions, just jot them down and we'll take time in between. So, this obviously, we have to declare every time we talk that it is not a consultation, but it's just an information sharing session. And obviously, if you pick up something that you're not 100% sure about or that is of concern, you are allowed to get clarity afterwards, and you obviously then can visit your doctor. So for today, the cancers that I'm going to focus on is the breast cancer. As you know, we've just closed off October, which is the Breast Cancer Awareness Month, and cervical cancer as well. If time allows, we will go through endometrial cancer, ovarian, and vulva, which are actually quite common in our communities as well. So this part is going to be nicely explained by Dr. Lubelwana. She's one of our menopause specialists in the area. She's very passionate about this portion. So as much as we are talking about cancer today, we felt it is important that you understand that part, because then it also explains quite a lot of things. So just a quick overview, because she will explain and go into details. When we are born, as we women, we are born with a certain number of eggs or in our ovaries, and from the time we are born, they are at least over 1 million, and as when we are born, we are out of our mother's wombs and we are growing, we reach puberty, they are declining, right? And as they decline, we get to puberty, and that's where it actually declines more. So remember, on every month, this is a person who's still younger, right? You've got recruitment of the ovary, the ovum, which is supposed to be preparing for fertilization so that a child can form, if I can put simple terms like that. So obviously, when that doesn't happen, then we go on our menses or our periods. So allow me also to just use normal words today. Otherwise, it's going to be complicated for me if I try use, the other words. So vagina is going to be vagina for today, and then only after what we'll pray to God, and then we go back to our other languages. So for the ease of explanation, can I please just use the normal medical terms? Right. So then we get to a portion after we've cycled every month, and then we finally get to a point where we are so happy the periods are gone. So we no longer have to waste money on pads and tampons. However, obviously we know for those that have reached menopause, it comes with certain things: hot flushes, brain fog, a whole lot of things that Dr. Sibu will explain when she comes, right? But the one thing that's important there is that once you reach a point of menopause, which is a year after the periods have completely ceased, you're no longer then supposed to bleed. So there's a few things I'm going to explain as we go, but I just wanted you to understand that a woman has stages or phases in life. You are young, you go through menarche where you start your periods, then there's the reproductive stage where you can get kids and all that, and then you get to a point of perimenopause actually first. Perimenopause is just the period before you go into menopause. So your periods go a little bit irregular and all of that, but Sibu will go into details when she comes on that. And then there's menopause. Right, so very important to understand your body, because with these stages, there's certain risks that predisposes people to cancer, right? So just a quick brief anatomy for those that are able to view this so that you can understand as we are going where, what, and what, right? So I'm a gynae, and most of the things we talk about, I usually say my job is below the umbilicus and just above the knees. Anything outside that is not my specialty. However, we do talk about breast because most of the time we are the ones that will pick up problems, but the breast is actually a surgeon's, they stole it from us, so breast is actually a surgeon's specialty, right? But we do know a little bit about that and we will explain. So for those that are here, if you're looking at this, just so we are clear, anyways, we're explaining what is what, right? We've got a uterus, womb, right? So the womb, this is the womb, right? And these are ovaries, and these are tubes. So when you ovulate, the egg will be released from here, if I can use just loose terms. The egg will be released, it will go through here, and if sexual intercourse happen, the sperms will go through the vagina and they'll travel here and they'll meet the egg here, and the fertilization actually happens in the fallopian tubes, which is somewhere here, right? Then the baby will move down and implant inside here in the womb, and here we've got a lining which is called endometrium. The endometrium is what sheds off every month when you're still going on your periods, and then that shedding will lead to the blood coming out, and that's actually how menses happen. So this is the vagina, this is the cervix. The cervix is the mouth of the womb. So, the question that you were asking, so when you're asking about the cervix being removed, it means that this part would have been cut off from your daughter, right? So this is the part that was cut out. So she still has the uterus, so she can still fall pregnant. The only risk is that because this is what holds the baby inside, she's at risk of obviously preterm labor. But usually the doctors, when they cut out that part, they put a stitch that helps to hold. But we'll get to that just now. But I just wanted us to know, when we're talking about ovary, where are we? Like ovarian cancer will be here, right? Endometrial cancer will be inside the womb. And then there's other cancers that happen on the walls of the uterus. Then the cervic or cervical cancer will be here. Vaginal cancer will be here, and the vulva is actually our outside area, right? So the labia and all of that is vulva. So when you have cancer there, that's actually vulval cancer, right? So I'm not going to explain the menstrual cycles and all of that because we have someone else who's going to touch on that one. So cancer, what is this cancer? So in the simple analogy which I use, which I think works for me, when we all have seen snakes, and the snakes shed their skin, right? Because they no longer need, or it's no longer working for them. Just in us, in our bodies, we've got small cells that are minute, and we can't see them with the naked eye. So when that cell is no longer needed for whatever reason, either it's dysfunctional or there's new cells needed. Remember, we've got different parts of the body, and just if you remember when you take a bath, you'll see that the water, there's those scale that is shedding. So that's just dead skins that are being shed off. So every part of the body has cells that are being shed off. It's just that we don't see them. Some of them are not necessarily shed off because they are inside the body, so they are cells in the inside, which are immune system bodies or cells that will then engulf or basically damage or destroy, right, those cells. So when those cells are destroyed, they are discarded somehow through the immune system. But if for some reason the cells that are abnormal, right, either damaged from radiation, from drugs or whatever, they do not die, and then they decide that they're going to multiply. That's actually how cancer happens. So it's abnormal cells that are supposed to now die for whatever reason, but they don't die, and they multiply, and they start to overgrow, because remember we said they're not needed, and they overgrow. For example, if you've got skin cancer, it means those cells maybe that would have been damaged by the sun rays, instead of them being shed off, then that cell decides, no, I'm going to ignore the immune system, I'm not dying. So when the immune system actually fails to eliminate that cell, and then it starts to grow. So all types of cancer actually happen like that. I'm not sure if that actually is helpful. But this is multifactorial, which means it's an interplay between different things, right? The environment that we live in, you actually asked for what causes it, I'll go into that. It's a multiple or multifactorial thing. Environment, our genetics come into play, and also our lifestyle. So, lifestyle. And, as doctors, we have been talking, or the medical professions have been talking about these things for a very long time, and to a certain extent, they've been ignored, including us. Sometimes we ignore the same things that we talk about. But you can never underestimate the importance of lifestyle, or the things that we actually do on a day-to-day basis that contribute to actually us having cancer, any cancer, for whatever reason. So, as I said, smoking, I think that's the one that we all know. And that's the one that actually gets the most blame. Yes, it is to blame, but there are other friends too, that we need to actually be blaming. So we know that smoking or cigarette has what we call carcinogen, which means those are the things that impair those cells now that are abnormal dying, or they will actually cause the cells to get damaged, and then when those cells that are damaged by the carcinogen, so a carcinogen is anything that causes cancer. So smoking, we know that a cigarette is a carcinogen, so it will cause damage to the cells, and if those cells don't die, then, right. So obviously, not everyone who smokes will get cancer. However, it does increase the risk of in fact, all the cancers, right? Then alcohol. We've always said a glass of they say a glass of wine puts the doctor away. There's lots of things that people say about alcohol, and as much as I know that different denominations believe in different things, we do know that the Bible doesn't say anything about alcohol being a sin. However, moderation is still important. As much as that one glass of wine may be healthy per day, but once you exceed the limit of 2, 3, it actually starts being detrimental, and now it adds on the risk of cancer as well, right? Then we've got aging, just growing up. Unfortunately, there's certain cancers that are more because of the age. These cells have been there for a long time. They're aging, and it goes without risk. They say that they've gone through radiation. Some of them have gone through smoking. Some have gone through alcohol. Some have just gone through normal body changes. So the age actually does put you at risk of certain cancers as well. Poor diet, right? So poor diet, right? So the diet, the things that we're eating, to answer your question, in the past, people used to plant, they used to eat food from the back of their gardens. There's a lot of things that we were just getting. Now we know there's processed foods, foods are being injected with certain things. So there's a lot of things that were never there, right, that are now there. And remember, I said everything is working together to now increase your risk of cancer. So the diet, the type of things we eat these days are actually very dangerous. Unfortunately, most of the foods that we eat are not even properly tested, whether they're carcinogenic or not. So that is also actually increasing our, right? Then we've got a sedentary lifestyle. Especially the kids, our kids these days. During school holidays, in the past when we were growing up, we'll be playing outside, all those sorts of things. Kids these days, they just on a PS5, in front of a couch, they're just chilling. Everyone is like, no one is playing outside anymore. No one is exercising anymore. And when we say exercise, it's not just going to Virgin Active only, but just brisk, taking a walk instead of, I live a kilometer away from Spa, but most of the time I drive to Spa. And we do acknowledge that, there's crime and all of that, but there's other safer things that we can do. You can come and run around the church, but just increasing exercise that also actually helps to boost your immune system, and it can, reduce your risk of certain, and unfortunately or fortunately, this risk or our lifestyle actually affects not just cancer. There's a whole lot of other things, your diabetes, hypertension, a lot of other diseases. So it's not just for cancer only, but it's for everything that we know. Then there's obesity. So we know that with the diet changing, right, with people no longer exercising, the risk of obesity is going up, right? And obviously there's genetics that come into play. There are people who are born a little bit more, their weight is a little bit higher than others. And we do acknowledge the genetics that come into play as well. But now the combination also, so now if you're obese, you're not exercising and you eat whatever, we have shows now on TV, there's these shows, and if you see the people that, what is it? Yeah, so there's these shows that you see obese or morbidly obese people, and you can see how much they suffer. So the heart is suffering, but this is also increasing your risk of certain cancers. So obesity is currently a crisis, and these were things that were happening overseas, but they've come to us as well in Africa. So it has been sharply rising for the past few decades, and we know that is now in a place where we can actually officially call it a pandemic, right? So all those things together are increasing our risk of cancer, right? Then the other thing that comes into play is our reproductive practices. For example, I'm going to go into details about this one. I was going to go into it, but also just to clarify your question as well. So we know that there's certain illnesses or certain cancers that come more with infections. For example, HPV is one of the infections that are either sexually, most of the time sexually transmitted. There are other ways to get it, but mostly sexually transmitted, and that is a risk for cervical cancer. So, and risk also for vaginal cancer, and some studies at this point in time are actually pointing towards breast cancer as well, but there we are still trying to figure out if that's true or not. But certain infections that come with sexuality, right? Low parity. In the past, especially the African or the black population, it was normal to have, like my grandmother, I think, had 13 kids, but I have 3 and I feel like I have a lot. So, now it's like people have 1, or I'm busy pushing my career, so, I'll have my kids at a later stage. So that low parity or having kids at an older age actually puts us at risk for certain cancers as well, like which I'll explain just now. Right, the drugs that we are using, especially people that have either been diagnosed with breast cancer, will be on tamoxifen. It also puts you at, although it's helping you with breast cancer, but there's also a small risk as well for other cancers. Use of oral contraceptives, combined oral contraceptives, they are good for certain cancers, but they may also slightly increase your risk for certain. So at this point in time, our life is almost like a balance of what is good, which one is the lesser evil, which one is a better evil, if I can put it like that. Breastfeeding, it's no longer in fashion to breastfeed because people look at you and they're like, you know, And there's certain things with social media that have taught us certain good practices are no longer good. Breastfeeding is actually good for your breasts. Yes, so HPV is a human papillomavirus. I'm going to go into it in details a little bit longer. But things like breastfeeding actually protects you from ovarian cancer and endometrial cancer as well. So there's just a mixture of things that are day-to-day sometimes that we need in order to actually help us reduce our risk of cancer. So I spoke about smoking as well. So diet we spoke about, and we do know that we are mainly made of water, right? And we always try to stress, and whenever I speak, I always make sure I have a bottle of water to pretend to be drinking water all the time, because sorry, I don't always drink it properly. But we always have said that 2 liters of water is good for you. We do know that that is not a proper fit for everyone. There might be people that are either hypertensive or in cardiac failure or renal failure who are supposed to restrict their water intake. But for a normal person who doesn't have any illnesses or not on any medication like diuretics or things like that, you should be trying to push your water, and we should not underestimate the power of water. So if we are made of water, almost 70% of our body is made of water, it means we need water. So things like that. You can drink tea and all the other things, but your fluid intake should be a point so that we are clearing, because our kidneys, right, and our liver is what actually cleanses our body, and our kidneys cleanse our body through urine, which means if you're drinking water, you're flushing out toxins and it comes out through water. So that's actually the reason why we need water. So I've already mentioned all of these things, and then I think Dr. Sibu will touch on this one, so I'm not gonna go into it, so that, but diet and supplements, I think she'll touch more on it as well. There are obviously things that are good for us, probiotics, and certain supplements. We'll leave that for Dr. Sibu for later, but exercise, as I said, very important. And exercise doesn't mean we are cycling or in doing the spinning class, but we always say weight-bearing exercises important. Walking is important. Yoga, swimming, those things that whatever that it is that you enjoy for yourself, go for that. As long as it's weight-bearing and it's constant. So if you exercise once a year, that doesn't count, obviously. So it's something that must be regular, happening all the time. And what we say about this is that the earlier you start, the better. So me exercising at the age of 70 now, I mean, it's going to be more painful for me than it will cause me problems more than, obviously you can start later, but the benefit is more when you start earlier. So we should be teaching our kids to actually exercise. I try and take mine to tag along, and try and keep active because of the type of lifestyle they're living these days. So the earlier you start is the better for you, right? Then, okay, this is a touchy topic because some people are very staunched believers of certain products that they use from the shops. I personally use water to clean my cookie, right? Nothing else, right? So the certain things we use in our vulva, vagina, that are not healthy, right? And they're damaging or destroying the bacteria that is meant to be there. And with that, obviously, you've got an imbalance of the pH, an imbalance of the things, and then those things actually predispose us to certain things, certain infections, right? So I always say that use water, right? And then there's things that are being advertised on social media, douching, unless you need douching for a specific reason, and the doctor has said douche for maybe someone who's got cervical cancer, you shouldn't be douching, right? And then steaming, I don't know what the benefits of steaming is. I don't steam. So, I mean, we can also speak to Dr. Sibu. She can explain if she does, but most of the gynaes actually don't do any of the things that are being recommended on social media. So that should tell you something, right? Then there's something called Candida. Most of us have heard it a million times. Is a infection, okay. I'm not sure if we're going to eat after this and if anyone has prepared a lunch at home. But when we do that green salad and then you sprinkle that cottage cheese, right? That cottage cheese. Has any one of you had that thing on their Someone is nodding and people are pretending, okay, I've had it, right? So that is not a sexually transmitted infection, right? I know people go and scold their husbands and stuff, but I always say that a vagina is a self-cleansing thing, and I always use an example of a nose. Most of us, when we take a shower or bath, we don't go into our nose and sticking things, but for some reason the vagina is like, people are doing things and I'm just like, poor thing, So we shouldn't be like sticking things unnecessarily there. The vagina is supposed to be having fluid, like the nose. It's not meant to be dry. And you'll notice that when you get older and you are now menopausal, it gets dry, and that's actually uncomfortable. So you're actually supposed to be a little bit wet down there, obviously not overly wet. Now, because of the things we put there, disturbs our pH, and then people actually end up having candida, right? Sometimes it's because of the antibiotics that we use. You'll notice that most of the doctors, if they give you antibiotics, they'll give you probiotics so that it prevents now this infection, because the imbalance that is caused by the antibiotics, they will kill the normal bacteria down there, and then the bad bacteria grows, and then you've got candida, and then it'll be itchy down there. You'll have ulceration and all of that. So that cottage cheese type of discharge, as long as it's white and it's not badly smelling, it's actually something that you can just go to the shop, pharmacy, get clotrimazole or any other antifungal cream, and you put it and you'll be fine. And just don't get used to using all these things that we use, right? So, okay. Then for the mature, we don't say older, for the more mature people, I'm not sure if anyone has heard about Kegels or Kegels exercises. So we continue to do that. Have you heard about them? Okay, so you've heard about them. Can you explain what you understand about them?
It's exercising, supporting the muscles in the pelvic area that support the uterus. They say you can do it on the toilet by just pulling up and letting go 10 times, and through the day you are supposed to pull up, release, and yeah.
I'm actually doing it right now.
Yeah.
So those are things that we can do. You don't even need to be like, obviously we prefer that people take time and consciously do it, or like take time out, and we usually say at least 40 to 50 of those a day are sufficient. That will actually help reduce your risk of organ prolapse, like your pelvic floor.
I just want to ask, when you're urinating, by stopping, starting, is that also part of it?
Technically speaking, yes. Yeah, right? So we know that as you age, by the way, just because you've had a cesarean section, it doesn't mean you are protected from prolapse, right? Because now the body is aging, just as the skin is no longer as ironed out, also the muscles are doing the same thing. So as you are aging, there's wrinkling of the skin, there's also weakening of the muscles. So that goes with age, that goes with pregnancy. So it's not just people that have delivered with a normal first, right? So even if you've had seizures, but pregnancy itself also increases your risk of prolapse. So everyone is supposed to be doing those exercises. You squeeze, you ease and squeeze. You're not squeezing your bums, right? You're squeezing your inside, right? So maybe a way to illustrate or easier one is that when you're holding your pee, but it's a similar kind of exercise. But you can go on the internet and they actually do try and explain all of that. All right, so this is my personal favorite. It's not my favorite cancer, but it's my personal favorite thing to talk about, right? As you heard, I'm an aspiring gynae oncologist, so this is one of the cancers that are very common to us as the gynae oncologist, so cervical cancer. So one of the most common cancers in the world, estimated at least 600 or so people annually are diagnosed in the whole world, and half of them actually die from cervical cancer, and most of them are in sub-Saharan Africa. So this is actually one of the most preventable, most preventable cancers. And the question that you asked was, what is HPV? So HPV is a virus, right? It's a virus that you can get it, as I said, from other ways, but most of the time it's sexually transmitted. And most of us, if you are sexually active, you would have had it in your lifetime, but then clear it naturally. But for those that either the immune system is weak, or even if the immune system is not weak, some people will actually retain that virus in their cervix, right? And if it's retained and it doesn't clear, it starts to integrate itself and into the cell, right? The cells in the cervix where I showed you. And it starts to cause the changes that are abnormal. And with years, that actually eventually causes cervical cancer, right? So, so remember this diagram I showed you. So the HPV will maybe just stay here, right? This area is vulnerable to HPV because as we are growing, as we go through puberty, as we go through our menses, pregnancy, there's a lot of new cells forming in that area. So we know that cancer obviously targets, cells that are fast growing. So that's the reason why that area is actually quite targeted. I think Dr. Sibu is arriving just now. So what are the symptoms? Early cancer, there's no symptoms. Most of the time there's no symptoms. That's why we say people must do pap smears, because that's how we pick it up. Then early vagina. In the early stages, people will have bleeding after sex, or they'll have this discharge that is just not going away, and they bleed in between their periods, or they can have heavy menses. By the time we have a very foul-smelling discharge, sorry, Sis Mbali, can you attend? Yeah. By the time we get discharge or incontinence, it's actually late. So the cancer is actually in that area. So our prevention strategy is this. There's three. So we say we avoid early sexual debut, we avoid smoking, and all the other things that we spoke about. And then we actually have HPV vaccine, which I think you spoke about. So HPV vaccine is a vaccine that is given to younger people. We are hoping by the time they get it, they haven't been exposed to HPV through sexual intercourse, and that will boost their immunity so that should they now engage in sexual intercourse, their body is ready to eliminate this HPV faster, and then, it sort of minimizes your risk of getting the cancer. It does not completely eliminate it, unfortunately, but we know that it does reduce. All right. Morning, Dr. Lubelwana. Welcome. Yes. Yes.
I just want to ask a question. So now, I know they're vaccinating the girls at 12, 13 now, and when my daughter was in high school, it was 16, 17, as long as they weren't sexually active. Shame, I'm discussing her. She only became sexually active at 22, okay? I want to know, and I mean sexual intercourse, I know she had oral sex. Can you get it from oral sex?
I think yes. My understanding is that, so oral sex, the HPV can infect any part of the body.
So it can be in the mouth?
It can be in the mouth. I think Dr. Sibu can add there, but my understanding is that even oral sex, because now, as long as that HPV finds its way into the cervix, so, we said we're just going to be open, Sibu here, we're just going to talk. We're going to forget that we're at church just for now. So, the HPV needs to make its way to the cervix. Whichever way it makes it, doesn't really matter. Remember that HPV you're not going to see anything, there are no signs. So it's not like if someone has HPV in their mouth, it's like HIV. If you've got HPV in your mouth, then you're going to show. So if someone with HPV on their mouth for whatever reason, transmits it to the penis, and then that penis will have HPV. And then the HPV, if that penis that is infected with HPV, whoever has sex with that unprotected sex, then that HPV will be transmitted to the cervix. So it doesn't have to be only like
The reason,
Yeah,
the
I think.
reason I'm asking that is because, I mean, I've obviously had a very honest discussion with her.
Yes, which is good, yeah.
She became sexually active at 22 and used condoms until she was 28.
Mm.
So and the doctor said she had her PAPs. Why did it happen? She's saying to me, Mum, why did it happen when I've only been having unprotected sex with the same sexual partner for 2-3 years now? So that's why I'm asking. Did she have a partner that it was carried in the mouth?
Most likely. But, okay, so we say that HPV is a causal for cervical cancer, but there is a small portion of cancer that's actually with a genetic predisposition, right? So we can't explain exactly on her. Obviously, we would need to examine all the things, but we do know that people are different. So for some people, it takes 10 years to get cancer. Some people, it takes 2 years. So it's individual. Sibu?
I'd just like to add to that the question that you were asking. So HPV has a propensity to attach to certain specific types of cells, and for like a heterosexual intercourse, it will go to the cervix or the penis on the men. And it can also attach on the vagina or on the vulva, the outside. And then if it's through oral sex, it can attach, it has a propensity to go to the throat and sometimes the tongue, but mainly it will be the throat that it goes for. So it likes or it latches on to certain specific types of cells. Yeah. And I'm not sure, maybe I missed the first part. Does your daughter have cervical cancer? Oh, I see.
Yeah.
So probably she had pre-malignant. Yeah. So I think what the explanation that
Yeah.
Dr. Ntshangase offered, yeah.
The other thing is, I mean, we don't really know. Just as I'm going to explain just now, okay, maybe let me go into it and then it might explain, and then we'll explain a few things. So now what we are trying to do with the pap smear is to pick up those early cells before it actually becomes overt or proper cancer, right? And in the early stages, which I just spoke about, that's when we can pick up the abnormal cells and we offer treatment. And the treatment that we offer is actually through cutting the cervix, right? So when we're doing a pap smear, we're sampling that part of the cervix. And when we pick up abnormalities in this area, all right, so this is a pap smear, you use the brush, right? So if there's any abnormalities in this area, you then be going back for treatment. We use a colposcopy machine to view, magnify, and then some form of stains, and we would actually be then cutting out that part. So we do cut out the cervix in like early stages, which the pre-cancer stages. So your daughter could have had that. And then when they actually have cancer, they do also cut it out, but it's different. So we can chat obviously afterwards and then try and see where exactly she is. But there's a difference when you are cutting out the small piece of the cervix as part of treatment of the pre-cancer lesion. But there is also another type of operation, a major operation, where we remove the cervix, and that only is done in the early part of the cervical cancer, and where you still have a younger woman who's actually wanting to still have kids. So we just need to be clear whether she had a trachelectomy or she had a LETS, because those are actually two different ones. And if she's had a LETS, which is the treatment for the pre-cancer lesion, that's just a minor procedure. And yes, there is some evidence that it increases the chances of preterm labor, but we don't have strong studies at this point in time. But if it's a trachelectomy, that's where you actually have the actual cancer diagnosed. That's a different type of cutting out. It's much more bigger and much more wider, but we can chat about that afterwards. So who is supposed to be having this pap smear? You don't need to be symptomatic. You don't need to be having a discharge or the things we spoke about. As long as you've been sexually active in your lifetime, whether it was once, you need to actually be having a pap smear. In the Department of Health or in the government sector, we say we start at the age of 30 and we do 10 yearly if you're HIV negative, so 10, 40, 50, or whichever every 10 years from wherever you start, but we're starting at the age of 30, and then 25 for those that are HIV positive. If you are in the private sector, like Sibu, you can do it every year or every second year, depending on the medical aid or whatever the person can afford. So, okay. So the department or the government actually limits us because of the funds. So we usually say up to around about the age of 50. However, I know, do you even have a cutoff? Yes.
So it depends also on sexual activity, on the person, whether you still have your uterus or not, and all those factors. But there is no like upper limit cutoff. But some people won't have it because of the circumstances, like they've had a hysterectomy where they've removed the uterus and it was not related to any abnormality in the cervix, then we don't need to do a Volt smear. If the hysterectomy had been done because of abnormal cells that were found in the cervix that could predispose to cancer, then we do a once-off Volt smear, and if that's clear, then you don't ever have to do a Pap smear again. So there's no cutoff really, but some circumstances may cause for the lady to not have to do a Pap smear after.
So as we said, it's not a one-size-fits-all. We always individualize cases, but the government, because of obviously the financial limitations, we usually stop at 50. But remember, I said this is a person who doesn't have symptoms. So if someone has symptoms, even if you are now 70, we are still obligated to actually do your Pap smear. If you had a Pap smear 5 years ago, and you're HIV negative, technically speaking, you're supposed to be having it in 10 years' time. But you now come symptomatic, we can't be saying we are waiting for the 10 years. So the age specifications that we put are generally for the general public, no symptoms. So you've got no issues or no big or major risk factors. When you start seeing things or discharges or abnormalities, we actually have to now test you, irregardless of your age, irregardless of your when your last Pap smear was done.
So now, you've gone through menopause, you've got a nice medical aid, and your GP says, sorry, we've got a test every 2 years. It's not necessary if you have no symptoms.
I think people sometimes think that we are just doing it because, so some people will do it for their discovery points every year because it gives them points, vitality points. So also I always say to the patient, technically we don't have to do it every year. If we've done HPV and we've excluded, there's none that's been detected and your cells come back, it's showing it's normal, we don't have to do it every year. But because you know what you're doing, you don't always know what your partner is doing. And so he could be bringing the HPV. So it's just a precaution. I always say I never want to see any of my patients becoming or having those changes that will lead to cancer on my watch. So that's how it ends up being every year. And if we have the resources for that, why not? Exactly. So that's how it ends up happening. And sometimes I'll say, okay, let's do it every other year or every 3 years, purely because you don't really always know what your partner is doing.
Yeah, so basically cervical cancer is, on a prevention, is better than cure. Those are the foundations of it. You don't have to wait to have a problem. That's actually how we get it. Yeah.
So now the other thing is, now you have a Pap smear every year or every second year, and they do bloods as well. Is that to pull out the cancers somewhere else? Because is the Pap only for the cervix?
The Pap is only for the cervix.
So in other words, the reason they're doing the bloods as well as that, screening for that, is to cover all bases.
So the bloods, and I think Sibu can add, the bloods are not specific to cervical cancer. We actually can't pick up cervical cancer through blood.
But will it
So it will be for
ovarian?
Other, yes.
Okay, so ovarian, fallopian, all that, uterine cancer? No, breast cancer?
Okay, I'm going to be going to breast cancer just now. So, but now the thing is, we don't know what bloods your doctor is doing. It could be hormones. The only hormone, or the one that we can pick up through blood most of the time is, okay, in fact, there's lots of tumor markers. So depending on your doctor who sees you, whatever bloods they are doing, we might, it's not that easy, but we do know that there's certain cancers which you will have markers in your system that can be picked up, like, for example, ovarian cancer. But for ovarian cancer, it's a little bit more complicated than just pulling blood. I'll touch on that just now.
I had a prolapsed bladder, and the gynae then inserted a pessary, I think it was called. Is that what it's called? What is that? What I had to change it every 6 months. And then he emigrated, and then I went to the next guy, and he said it wasn't necessary to have it anymore. But my question is, I was told by a doctor some years back I don't need to do a PAP anymore, and I haven't had a hysterectomy. I don't know why, and I was at a gynae and he never suggested doing a PAP, so am I in the clear?
When was, I think it depends. When was your last pap smear?
I can't remember. Probably 10 years ago?
I think obviously one has to look at your history, do a proper examination, and look at your risk factors. And
I'm not sexually active.
Yeah, so maybe your doctor remember your doctor has your full history and they know exactly why they are saying there's no need at this point in time.
Except I've moved and I've got a different doctor. So
yeah, but you don't have a different partner, so.
I haven't got a partner.
Exactly, that's what I mean. Remember, we still need that HPV in the, yeah. Okay, but I know Dr. Sibu is going to talk about, I don't know if you're going to touch on pelvic floor. Yes.
Thank you, Doctor. I saw your previous slide had a picture of Gardasil. I think that's the vaccine, yes. Do you want to talk a bit about that one, Doc? Because I've seen patients, especially private patients, in the pharmacies, in the clinics, in the pharmacies. They like asking for this vaccination. Is it for certain age groups? Because I was thinking that maybe, but it looks now like anyone can take it. Do you want to talk about it, Doc?
Yeah, so, okay, so remember, we've got the public sector, we've got there, right? In the public sector, it's given solely to the younger ones. It's actually given in the schools. So it's a school health program. They go to the schools and they vaccinate them. And those, they actually have a cutoff for when, right? So if you are older, they actually don't give you. In the government, in the public, in the private sector, it's dependent on your affordability. So preferably, we want people to be having this HPV vaccine earlier, prior to them being introduced to sex. However, you can still have it even when you're older. I know we've been having studies coming out and the age has been increasing, and I mean, the latest I've read is that actually there is no age cutoff. But if you are sexually active, you actually, even at my age, I can still have it. So I don't know if you're not, I mean, she's in private, so, but it is something good to have if you can afford it. And there's obviously different types. Gardasil 9 is the one that covers most of the HPVs, but I know in the government sector we give a different one. So Gardasil 9 is what is available in the private sector. So if you are able to afford for your daughter, for your anyone, then yes. Especially for those that have risk factors.
Yeah, I think that's very important what you're saying, Doc, because, like, for example, at the university, we teach students health promotion and disease prevention. Now, like, I know current students, what they know is the previous version that you said, as it is done in the previous sector, in the public sector, because we normally, invite people from the eThekwini Health District to come and teach students, and they will emphasize on the vaccination from the children from grade 4.
Grade 5, yes.
Grade 5, So that's the version students will know. So what I'm trying to say is that what you're saying is very important, that if people can afford, there is no harm in having the vaccine. That's what I'm hearing.
Yeah, not only is there no harm, actually, I advise my patients, so I can always administer the vaccine, but it's more expensive when they get it from me because I don't order large stocks. So I always say, when you go to Discam or Clicks, ask for Gardasil 9 because that one covers most of the high-risk HPVs, yes. So it covers against those, so you've got more protection. But it still doesn't mean that what we get from government that doesn't work. It does, but it's just got limited coverage in terms of protection. And also, one thing I always stress, while we focus on girls, that's good.
I was going to add.
We also need to give our vaccines to boys because most people have heterosexual relationships, and so girls get it from boys, and usually boys are carriers. They won't manifest, and there's no test that, like with women, you can do a pap smear that will tell you that there is presence of HPV. But with boys, either they come up with warts or they are just carriers.
Yes.
And every time they have unprotected sexual intercourse, ladies are at risk. And one thing about HPV, maybe just to also reassure patients who get HPV, one thing I always say is over 80% of women will have HPV at one point in their lives. It's just that one of the reasons why the screening starts late is because the body clears the HPV by itself, so it's self-limiting up until age 26, 27, which is why the guidelines say you start screening from age 30, because even if you've had it from an early stage, your body has opportunity, has the strength, is capable of getting rid of it. So we don't want to rush into clearing it itself and expose to a patient to side effects like what Dr. Ntshangase was talking about. So we allow the body to clear it, and then if it doesn't clear it, then we can intervene now and take the patient for that procedure where we're removing the abnormal cells in theater.
Yeah. Okay. I think we can touch on other things later when we open up for questions. So, just to briefly touch on, okay, my thing is no longer working. But yeah, so just remember with cervical cancer, we always say prevention is better than cure. We need to encourage safe sexual practices. That's condomizing and obviously limiting the number of partners, but that does not completely protect you. HPV is sexually transmitted, as we said, so we need to do our regular pap smears for those that are at risk and the HPV vaccine. So with that being said, we just want to move on to this topic that has been, all over for October, and this is actually it's my second favorite. As I said, not favorite cancer, but one to talk about. And as I already told them, Sibu, that the surgeon stole this one from us, so it's actually not our specialty. But we are, seeing women on a daily basis, so it only makes sense that we know about it, and we actually do care and refer patients and do necessary tests. So we've just closed October yesterday, and the slogan is always supporting those who are either still fighting, and we do acknowledge that some people would have lost their loved ones. I mean, I recently lost someone close to me as well from breast cancer, so it's actually a reality. So the awareness basically, or this awareness has come about because we are just, it's not that we are, exposing breast cancer as a good thing. This whole pink drives and everything that's happening is to just increase the awareness so that people are prompted to actually do the necessary tests. And I like this because, when I was going through the history of actually how cancer awareness started, it's actually interesting that there was a lady named Charlotte Haley. She was 68 years old when she started a movement overseas where she was actually hand making peach ribbons, and because she was a survivor herself, and she was trying to actually tell people, there's breast cancer, because most of the time when you are diagnosed, you're alone, you don't know anyone who's had it, and you sort of isolate yourself. Meanwhile, you can actually get help or support, emotionally or otherwise from other people, and you can actually educate your family as well. So she started this movement initially. So this whole movement that has moved to pink or even other ribbons was actually started by someone. So I always encourage, if anyone in your community, in your church, wherever you are, you do not need to have 1,000 people, just in your groups for when you're discussing other things, you can actually discuss such topics. So this then obviously was eventually taken over by different industries and more commercialized and moved to pink, but this is actually how it started. So breast cancer is actually a very common thing. It's the most commonly diagnosed cancer. Cervical cancer actually follows it. So there's a lot of people that have been diagnosed. Some are living with us, and people actually don't talk about it a lot. And what is actually important is to know is that men can get it too. We were just talking about HPV and males. Actually, men can get breast cancer, and it's actually more aggressive when it's in them. So it's important to remember that. It's not only for older people, so even the younger people. The youngest person I know personally, and obviously in those that are in practice, they would have seen younger ones, was 26. And I know someone was speaking yesterday, and they said the youngest they've seen is 22. So it is actually a disease that even affects the younger ones at this point in time. So it's not just for old people. In the past, we used to say, it's a disease of the white people, but now we're realizing everyone is getting it. So it's not just it's not about race. It doesn't choose race. It's for everyone. Few risk factors that are there. And just because you've got risk factors, it doesn't mean you can get that cancer, right? Nulliparity we already spoke about earlier, right? And I think actually most of these we actually have spoken about, except for radiotherapy to the chest for whatever other reason. You could have had it because you had another cancer that needed radiation in the chest area, or the people that work in the X-ray department on a daily basis, they are exposed to that. But obviously now there are shields that have been developed to try and protect them from radiation. So radiation is that. And then there's family history as well, especially people that have had or they are diagnosed with BRCA mutations. So it is important to know if your relative, especially a first-degree relative, has been diagnosed from breast cancer, then you are at risk. So you need to actually screen more than other people or the general population. Right. So,
When someone has been diagnosed, does it matter how they got them? So I'll make an example. Will it always affect the next generation, even if maybe they were a radiographer and they got it because of the type of job that they were doing? Or they were increased risk because of the type of job that they were doing, not necessarily that it was genetic.
Yes. So you'd remember that in the beginning we said that the risk factors for cancer, there's many, all right? And there's an interplay. So the ones that are genetic generally get, the risk gets passed on. So it's not that the cancer, but the risk is carried through generations. So that one would have been a mutation. What do we call it? I forgot the name. No. This is like the person who's exposed to radiation. So it's not a familial mutation. It's a sporadic, I think. Yeah. So it's a mutation that's new to that person. So that one is not necessarily passed on because it's like a risk of smoking. You can't pass on the risk if you've got cancer because of the smoking, unless obviously you got people with the secondary smoking that, the children, if you are smoking and everyone who's with you is obviously exposed, that's a different one. But from radiation, you can't pass that mutation on. It's different if maybe you were pregnant and you were working there and your child was exposed, that's a different story, but that generally is not passed on. So, all right. What is important here is that we always do our self-breast examination. So if you go to the internet, there's different types of pictures. They will show you how to actually do this, right? But what's important to know is what are you looking for when you are checking your breasts. So you check both your breasts, and we usually say on a monthly basis. And for those that are still going on your period, we say maybe 7 days after you do. Or for those that are now postmenopausal, obviously you no longer have a monthly cycle. You choose a specific day a month that you're not going to forget, and you check your breast on a monthly basis. So when you're checking, you actually go around both, right? So You make sure that you're in front of a mirror, you are naked, obviously the top part, you are able to see both your breast, and you compare the sizes, you look at the skin, are there any orange, we usually use put orange, which is an orange peel type of skin change. All right, you're looking for that, and you also squeeze as well, so you're looking for any discharge that's abnormal. You are also looking for lumps, right? Just because you have a lump does not equate to cancer, but when you have a lump, it means we must actually go check. You check for pain, and basically color changes. So there's a lot of things. So it always imports. I always tell people, you must know your body, like you must know your body, because when you know your body and you know certain things, you know where you have marks, you know where you have scars. When you start to see something new, then you must actually then consult the doctor so that you can be tested. So you do this obviously while standing in front of a mirror. You can do it when you're sitting as well, because the different positions that you are using will elicit different things. It's also important to check your armpits or going towards your armpits, because the lymph nodes or the glands that will carry the cancer and spread it are actually in that area as well. So yeah, so as much as you can, that the monthly thing, right, is now you are checking for signs at home yourself, right? You don't need a doctor for that. That's on a monthly basis. Then you can, as part of your annual checkups, when your doctor sees you, they will actually need to do your annual breast exam as well. Here we're actually looking for things that are abnormal so that we can pick up with our hand. But remember, with the cancer, there are early stages which you can't pick up with the hand, and that's where you need your mammograms, all right? So just a bit of humor. There's a reminder that, mammographing your boobs is also important, as so it's basically Instagramming them. So make sure that with your checkups, you are going for the mammogram. And most people complain that, no, it's painful. It's not that painful. It may be uncomfortable, but I always say that the discomfort for those few minutes may save your life and save you a whole lot of pain. So rather you do it. So this one it's just an X-ray picture that is specialized. It will pick up early cells that are abnormal, right? And then we usually recommend it from the age of 40. And anyone who's 40 and above, we say annually do this mammogram, or every 2 years, depending. But those that have risks, now, this is when you have a family history of someone that has been diagnosed, and this is not your mother-in-law, a direct relative, right? Blood relative. So those actually have to consult with their doctors, and they would need to start a little bit earlier. And that one is individualized according to when the person was diagnosed. Did they have the mutations that are passing on to the family? What type of cancer did they have? So that is specialized. So when you have a risk like that, you actually need to be seen by the doctor, and they'll give you specific indications as to when do you need to be doing your mammograms. And obviously for some people, they may need ultrasounds or MRIs. That is more specialized. But your general public, we say from the age of 40, start doing your mammograms. I'm actually guilty of not doing one this year. So, yeah. So as we've already said, prevention, we've already mentioned in the beginning, Sibu, we spoke about what predisposes you to any cancer. So we always say the same things apply, you're reducing smoking, reducing your alcohol intake, your diet, and all those things. So those then actually, they now come in every cancer. So we're not gonna go specifically into it. So if they found a lump, they will then take you for a biopsy, because now some lumps may be benign, which means they don't actually have cancer. So once you find a lump, do not be scared. Go to the doctor. They will then do what we call a biopsy, and then a biopsy will tell whether it is actually cancer or it's something not to worry about. So you can't just sit at home with a lump. You must actually have it checked. Right. And management, okay, just in management, I'm just going to talk about it in general, because I'm going to hand over to Dr. Sibu just now. Management of cancers in general, this is divided into a few. So we usually have what we call surgery. Surgery is when they're going to cut out whatever cancer. So if it is cervical cancer in its early stages, we need to do what we call a hysterectomy. If it's breast cancer, you need either mastectomy, depending on whether they're both sides. Your doctor will obviously guide you directly according to whatever cancer you have. So that's usually surgical, and that's early stages of most of the cancers. Once we get to a point where we say it's metastasized, mainly it has moved to other parts of the body, and sometimes the doctor will tell you we can't cut it out, right? There's other forms of therapy, like chemotherapy, All right. So chemotherapy is an IV drip which carries chemotoxic cells that will actually kill the actual cancer. And unfortunately, those who have experienced it or know someone who's experienced it, it comes with a lot of side effects, including falling of hair and a whole lot of things, but it's usually for the benefit to the patient. And then the other one is radiation. And radiation is basically a big machine that uses X-ray or radiation waves to actually directly go to the actual cancer and kill the cancer cells. Unfortunately, with all these things we are talking about, chemotherapy, radiation, you are targeting the cancer, but normal cells will also, that are in the vicinity, will also die. So hence you find that there's a whole lot of other cells that are affected, like your blood cells. You find they've got decreased white cell count, which is part of your immunity, and then they'll get sick more because, you know, as we are trying to kill the cancer, some of the normal cells that we need will also go down during the treatment. So there's a lot of side effects that come with chemotherapy, and then it's always important, we must never underestimate the power of support. So if you've got someone you know that has been diagnosed with any type of cancer, support means a lot. It could make a difference between them stopping the chemo because they've had it and continuing the chemo, or whatever treatment that could be actually saving their lives. So there's different stages of breast cancer I'm not going to go into, but you know, for whatever reason, if you know someone and you've been diagnosed with breast cancer, you're not alone. There's a lot of support out there. You know, if you've been watching or checking the news or social media, there's so many foundations that are out there to support, and all you need to do is just Google cancer support, and depending on whatever type of cancer you have, there's so many people out there that are busy supporting everyone. One that I'm just gonna touch on one sentence is endometrial cancer. Endometrial cancer, remember we said once you've stopped your period completely for about a year, you shouldn't be bleeding. So if you start bleeding, right, it means you are at risk of what we call endometrial cancer. And remember, endometrium is what sheds when we're on our periods. So now, if you are now menopausal, there shouldn't be anything shedding and you shouldn't be bleeding. So if you start seeing blood or bleeding, it means we actually need to check it. It could be what we call hyperplasia, which is not cancer, but you still need to have it checked so that we can take a sample and then make sure that it's not endometrial cancer. And with endometrial cancer, obviously, there are risks that I think the one that people like to talk about, especially with breast cancer, is HRT, which Sibu will touch on just now. And then there's ovarian cancer. Ovarian cancer, if it runs in the family, you must have it checked. Unfortunately, ovarian cancer, we usually pick it up very late because it's small and the cyst grows and grows and grows. And only once it's big, people start to get symptoms, and they either now have this big lump they're seeing, and they now have early satiety, which means, you know, and they've got pressure symptoms. So that one is very difficult to diagnose, and it's difficult to screen. But if you know there's a risk in the family, that's where the bloods now, which we were talking about, become important. But obviously, we risk stratify according to, you know, the family history or what you have, and they'll also be doing ultrasounds to check if you've got a cyst and if the cyst is growing at what rate and all of those things. Yeah, so on that note, I think I'll end there, and if there's any pending questions, we will take them as we go, and I'll hand over to Dr. Lubelwana. Yeah, you have a question? So,
is there a link between endometriosis and endometrial cancer?
So we know that people that have had endometriosis, they are a little bit at risk for endometrial cancer, yes. Okay. But it doesn't mean everyone who has endometriosis will have endometrial cancer.
I had endometriosis, I had postmenopausal bleeding. They did what you said, went into theatre. I actually hemorrhaged, went into theatre. And that was clear, but they said it was very common in women who are overweight.
Yes, remember when we spoke about the risk factors, I spoke about obesity, right? Now, when you have a high fat or peripheral fat, you've got conversion, or you've got estrogen being produced there, and we know that estrogen is one of the risk factors. So obesity is actually a risk factor. So it goes back to what now we understand why.
It wasn't very polite about it, because you're fat.
we apologize on behalf of our colleague. Sometimes we come across very rough. But yeah, on that note, thank you. I will be on the floor to take any questions, but I would like to introduce, I don't know if you've sent your bio. Okay, I would like to introduce, should I? Okay, so Dr. Sibu Lubelwana is one of my senior colleagues, actually. We met back in the days when we were training, and she's one of the people that I admire and enjoy looking or watching her talk. She's recently hosted a Menopause Summit, so if you're on social media, you must check. I'm sure you'll have one next year. Please let people know early. But her passion, one of her passions, she's got many, but one of her passions is menopause. So she'll take you through that, and obviously it links into some of the things we're actually talking about. She's a mother, she's a gym fanatic, she's everything. But without further ado, please come on the stage and take over.
Thank you so much. And thank you for inviting us to talk about important things as women. I love it when churches also see the importance of ensuring that women are taking care of themselves. I've been here for, my daughters are at St. Mary's, so I've been here for the choir, I've been here for Bryce's assessments, you know, the career, yeah, so I've been here a couple of times, but I've never stood here, so thank you. And thanks for that beautiful introduction, Pam. Thank you, and I get so much energy from you as well. And I'm so happy today that we get to share the stage, because I know we are cut from the same tree. We're just one of those people who God set us up to do gynae just so we can use the knowledge that we have to help women to woman better, basically. And whenever I speak to women, one of the things that I always say, I want to live with women, even if you don't get the nitty-gritty. I don't have slides, sorry. Even if you don't get the nitty-gritty of the science of things, but if there's one thing I really purpose for women to walk away with is falling in love with themselves and being women. I think we've been somehow socialized to not really like being women, to hate everything about the core of who we are, starting with having our periods. So before I hosted a menopause summit, I always thought I'd host a menstrual cycle something, because that's where, you know, my focus was on. And in like talking to young girls, whenever I have patients, young patients, I love it because I get to expose them to the different side of being a woman, you know, and to understand what God has blessed you with is actually, it's good enough. You know, you are a woman, and it's not a mistake that you're a woman, and you should just accept yourself as such and walk complete in that. I've got two actually models, and unfortunately I left the other one accidentally. I thought I'd brought it. But God has created us as women complete with everything that we need, with all the body parts that we need. When it's announced it's a girl, you have all of this. It's just that the size is smaller, the function may be a little different at birth, but you have all this. And even the oocytes, so the eggs that are produced by the body for procreation later on in life, you are born with everything complete. In utero, we have about 7 million of the eggs, the oocytes, okay? And that process of disintegration and reduction starts from when you are in your mother's womb, and the ovaries will reduce to 1 million by the time you are 1 to 2 million by the time you are born. By the time you get to puberty, that number has reduced to between 400 and 500,000. And then you get to puberty, you start your period, and then every month when you go on your cycle, there will be a cohort of these oocytes, the eggs, that are released, with one dominant one, which is the one that is ready for impregnation, for fertilization, so that you fall pregnant and have a baby. But that one will always have 10 to 15 that accompany it. And so that process goes on throughout our life until there is nothing left in our reserves. That's just the summary of woman, and that by that time you are in menopause. There's no more of the oocytes, and you're done. But you're not done as a person. You're just done with that part of your life. As women, as people, we are hormonal beings, but as women, I always feel like I think we are a little bit more hormonal beings than men. For men, it's generally the testosterone levels, the dopamine will be there. We all have similar hormones. It's just in different amounts. And also what varies with us is the amount that our surges go high, the amount of estrogen surges that we have throughout our cycle. So I can see that most of us are not in that reproductive age, but I just like to lay a bit of foundation so that we sort of get to understand our bodies, and also so that we can talk to our daughters, our granddaughters, and so they help them to understand themselves better as well. And we're able to shed a little bit of light on womanhood in general. So when we start our period, what actually causes for us to go on our periods for the first time? So the body just gets like a switch on to say, now you can start with those increased surges of the estrogen and the progesterone levels. Those are the two main hormones. We also have testosterone, but the two main hormones that control our lives and control our cycles will be the progesterone and the estrogen. And when we get the surges and the ebb and flow of the hormones, that's when our cycle becomes a little bit different. And with the cycle happening like that, we are different people depending on where the hormones are at that time. So I always say, when I speak to women who are maybe in relationships or who have husbands and partners and all that, and the partner is like, geez, I mean, it's like you're somebody else, you are a whole different person at some stage in your life. And so let's not run away. Yes, we are a different person depending on which hormones are high at that point. So people must just understand that is us. That is who we are. It first starts with us accepting that though. So when you get your period, that's when estrogen levels are at their lowest point. Both estrogen and progesterone are at their lowest point. And at that time, your body is feeling a little bit tired as well. You don't feel like, even me as an exercise fundi, I won't be feeling like I've got all the energy to exercise at that point. I'll feel more like doing yoga or something, that's less energetic. And even my mind is feeling like, I just want to slow down a bit, And you rather sit with your notebook at that time and just like journal things. And that's the power that God has given us, that we can just sit during that time and just like withdraw from life and allow yourself to. So let's teach our girls to allow themselves to go through those emotions and go through that time where you feel like, I don't want to be much in the social circle. If you don't feel like sport, I always tell my girls that it's fine if your body is telling you to just like slow down, do that. So don't go for coffee to silence your body, because the body is the best thing that can tell you what's going on with you. I always tell my patients, even when they give me a history, that the reason we have time for history is so that we can get to understand you better, because every person is different, like Pam was saying. Every person comes with their own set of risk factors and so forth. And the only person who really helps with the diagnosis is you. So that's why we have that interaction and that chat before we can get to the bottom of what's actually going on. So let's teach our girls to just allow themselves to just be. So if you're not feeling like going for sports, let's not be like we grew up in a time where we were forced to do whatever the school says we must do, whatever we're supposed to do, you have to do it. But I think we are learning more and more that we actually need to also go with the flow of our bodies. And if our bodies are telling us to slow down a bit, it's okay. So don't go for the coffee just to oppose what your body is telling you to do. Just listen and allow your body to take you where it wants to take you. And so that's the menstrual phase. So the phases of menstruation there's 4 phases. There's the menstrual phase, which is when you are actually menstruating. And then after that will come the follicular phase, when now the follicles are building up again to prepare for the next cycle. In the follicular phase, you start to get progesterone levels starting to come up, and your estrogen levels are starting to come up as well. And during that phase, you find that even your energy levels are also starting to come up a bit. So you feel like you've got more strength. So if you are someone who exercises, that's the time to be doing your strength training. You can do some boxing because your energy levels are also coming up as well, running, whatever it is that you do. But also, interestingly enough, one thing that's, in research we're finding a lot is that there's estrogen receptors in the brain as well. So that's why people, when they get into menopause, they have the brain fog, because those brain receptors are no longer getting estrogen. So during that time, during the follicular phase, I always tell my girls, this is the time to really sit down and focus on your studies, because that's when your brain receptors are also coming up, with the estrogen levels rising up as well. So your mind is able to be a little bit more creative, because whatever is happening in your ovaries is what's happening in the rest of your body. So there's going to be a new cohort that's going to be produced now, that's going to grow up, and the follicular phase is all about that growth phase. So even in your brain, there's a certain growth that happens, and that's why you're able to come up with new concepts at that time. If you're a working woman, you're in, a space where, you can use it by all means. And then after the follicular phase comes the ovulation phase, which is the best phase, because the hormones are at their highest, your mood is at your highest, so that's why you are a different person, So your husband, when he says, it's like you're a different person, let's not argue. Just say, yes, I am a different person because of the influence of hormones. So expect to see 4 different people and break it down to him. Like my husband, when I still had my periods, he knew my cycle. And he knew when the perfect time, men love sex, so he knew the perfect time when he would get some, from me. And that's during ovulation. Because your energy is sky high and you're just feeling good, you're sociable. If you want a raise at work, that's the time to speak to your boss, because you're just charismatic. People like you at that time. I always tell my girls, that's the time to come to me and ask for money, for airtime, for whatever you want when you in the ovulation phase, because you're just charismatic. People like you, They want to go to movies with you, and it's all good. Everything is good because you give off that positive energy. And so it reflects back also on the people around you. Unfortunately, it's the shortest phase of menstruation, lasts 4 to 5 days, but it's the best time. So for people who are also trying to fall pregnant, that's the best time to, try and just make sure that you intimate with your partner, because that's when the eggs are released as well. And then after that is the luteal phase. The luteal phase, the hormones start to go down again. Again, your energy levels go down, so you're feeling a little bit like just sitting on the couch and having a warm cup of tea or Milo or hot chocolate, whatever, muffin, and watch a movie. But also what's been noted is that there is BDNF, the brain-derived neurotropic factor. It's at its highest. So that's the time to learn new information. So please tell your girls to listen to their bodies and go with their cycles and use it to their advantage, because this is our gift from God. It's just that it has unfortunately been introduced to us very negatively. When my firstborn daughter had her first period, well, I had been speaking to them even before. So when she came, she woke me up in the morning, Mom, I need you. And I knew that, okay, this is the day. She's having a period, and we went to the bathroom, I helped her through, and so forth and so forth. And then in the end, I'm like, congratulations, baby, you know. And hugged her, and, you know, we celebrated. And then I asked for her permission to tell my sister, my big sister. So I told my sister. And so my sister's like, oh, what did you say to her? And I said, congratulations. And my sister's like, why are you lying to her? Why are you doing that? Why are you giving her false information? People say congratulations to something good, and the period is not good. I said, no, but it is. My understanding of the period is good. My understanding of what it is to us as women is it's good. Yes, everything in life. So the other uterus that I have, it actually shows the other side of the uterus. So this is save for this is a perfect uterus, perfect tubes, perfect ovaries. But the other one, it shows the fibroids, it shows the endometrial deposits, it shows the endometrial polyps here, it shows the lesions that you can get in your cervix and all that. So it's got the abnormal, it's gross, you know, to say the least. It looks gross. And unfortunately, as much as we are created this way, we can go to the other side. And so that can make periods difficult. Because when you've got fibroids, your periods are going to be heavy. You're going to have backache constantly. Your sexual experience is going to be painful as well. When you've got polyps, you're going to bleed. You can bleed heavily, you can bleed even outside of your cycle and all that. When you've got endometriosis, that will lead to painful periods that is outside of the ordinary. You know, I always say to moms whenever I come into contact with people that please allow your daughters to tell you how their periods are, what their experience of the period, because honestly, when it starts to affect a person's quality of life, where they feel they don't want to do sports, or they feel they don't want to do even the stuff that they really like, because unfortunately with sport, sometimes people think it's just an excuse to get away from doing sports. But some people actually love sports, but the periods are so severe, it takes them away. So when it takes you away from doing life the way you like doing it, then it's a disease. Anything that happens in your life that changes how you want to do life is a disease. So that's how we should look at it. So even a normal process like periods, when it affects how you do life, there's something wrong, and that needs medical attention. And so we should even allow our daughters to be able to express themselves to us, and we should also take it seriously when they experience that. So that's, you know, in a nutshell, the woman of reproductive age from teenagehood to when you're experiencing issues with your periods, or you're having fertility issues, which you need to get medical attention and have that attended to. You can stop me at any time if you have any questions. And then we get to the period that I spoke about, the period when now your ovaries, they stopped functioning. They no longer have, there's no more oocytes, basically, because we have a specific number. And when you get there, it just depends on the number that was allotted to you. We are different people, and you know, things will happen differently to each and every one of us. On average, though, we always say that menopause will be around age 51, or between the ages 47 to like 54. So that's when menopause can start happening. But what we are also finding is that the symptoms that trouble women is not specifically when you actually stop having your periods. The symptoms actually trouble women in perimenopause. So that's before your periods actually stop. And what happens is you start to get periods, times where you are not ovulating. And so the month you're not ovulating, you'll find that you skip that month, you don't go on your periods. Sometimes you skip 3 months not going on your periods. And during those times, you may find you are experiencing some symptoms, like you find you are tired all the time, you find you start having some hot flushes as well, you having night sweats, you're having vaginal dryness, because estrogen, like we said, affects top to toe. It affects every single part of your body. So it's very important. That's why we love it. That's why we treasure it when it's still there. And when it's not there, we need to assess and see whether you need to have any top-ups if it's affecting your life drastically. So women may experience those symptoms, night sweats, hot flushes, the brain fog, vaginal dryness, some joint pains as well. And sometimes when you put it that way, people don't quite get it, but when you put it according to what you experience, people get it. So like you have a feeling where you holding your phone, and that's happened to me, and you asking, guys, please help me look for my phone. Where's my phone? Like, where is my phone? Or you have your glasses on your forehead, yes, and you're like, where are my glasses? I want to read. Where are my glasses? I can't find them. By experience. Or you're lying in bed and you've got one leg sticking out because you're hot and cold, and it's fluctuating between, Or your husband wakes you up and you're drenching in sweat because he's like, hey, what's going on with you? Why are you so sweaty? What's going on? Those are all experiences, practical ways we experience menopause. And most of the women grew up knowing that, okay, I'm at that stage of life and that's that. I need to just accept. But this generation is saying, no, we're not going to accept that. What can we do to help? Because I can't afford to, in the middle of a consultation with a patient, to be forgetting what I want to say to my patient. So what can I do so that doesn't happen with me? I need to do something so that I'm still functional, and I'm postmenopausal. That's me. That's my disclaimer. But I'm not done with life. Like, I have so much I want to do, and I want to do it still having energy and, still feeling fit to do all that I want to do. So that's where we are as women, either perimenopause or postmenopausal. We're saying, no, what can we do to still make our lives functional, and while we function, to do it good. Like we're saying, how can we influence our lives so that we're focusing more on not just lifespan, because lifespan is the number of years you are living. We want the 120, well and good, but not only do we want that, we want that feeling fit, so we want a health span. So our focus is more on getting ourselves in a good state of health for longevity. And that we still feeling good. And all parts of our lives are impacted positively, all right? And so how can we do that? How can we impact our lives so that, even when we get to the perimenopausal stage, we're still functional and we get over to postmenopause? Let me maybe start by doing the definition. So perimenopause is when you're having the on and off symptoms. Your hormones are fluctuating up and down, specifically estrogen and progesterone. They may be up, they may be down 1 minute, and you may get your periods and not get it. And you may have some joint pains here, some brain fog, some this, some that. And then menopause is, so let's say your last period was on the 1st of November 2024. So it means today, 1st November 2025, you are menopausal. You can say by definition, you are in menopause because 12 months has elapsed with you not having a period, right? Tomorrow, when you wake up on the 2nd of November, you are postmenopausal. So you don't linger in menopause. You are just menopausal for the day when it's, 12 months since your last period. And then the following day when you wake up, you are postmenopausal. And any bleeding thereafter is abnormal, like Pam was saying, that if you bleed after the age of menopause, that needs to be investigated, okay? Unless you are on hormone therapy, because if you are on hormone therapy, you should expect a bleed. So those are your definitions, and people can categorize themselves as to where they are. And the symptoms can be anywhere in between. So one of the main things, one of the sort of easy things to do that I always encourage women when I speak to women, even who are in reproductive ages, is you start early. So you don't wake up just when you start having perimenopausal symptoms and say, now I want to prepare for menopause. No, you prepare now. Get your body strong now. Do the right things now, so that your body is sustaining you. When you get to menopause, it's a smoother transition. So the way you eat, for starters, will have an impact on how you transition into the menopausal stage. And this has been shown because there are studies which have been done in, the traditional aborigines, those people who eat like raw foods, who don't eat lots of like these high fat, greasy takeaways that people expose themselves to. Their experience of menopause is different. For them, it's just like a smooth transition because their bodies are just not exposed to all the toxins. But when they found that the ones who are exposed to all these high fat foods and fast foods and the diet that we are mostly exposed to, that's easy to get hold of. So those are the people who will usually experience menopause differently. One of the questions that I've always, so Pam, we need to do a study on this. I always wonder what the women in Nongoma, in a great town, like how are they experiencing menopause? We're talking about it here, but what's their experience of menopause? In King Edward, when I was there, like it was 1 or 2 patients that would complain of menopausal symptoms, but we see seas of women. So it can't be that they're not experiencing menopause. Is it maybe the culture that's making them to not talk about the symptoms, that they've shut themselves down to say, anyway, we expect this. It's supposed to happen because you've reached that stage, there's nothing we can do. But no, there is a lot that we can do. So diet is one of the things that, you need to take care of. Exercising is one of the ways that you can also make your body to transition better into menopause. And not just aerobic type of training or exercise, but strength building is what will really keep you in menopause. That's the type of exercise that you really need to go for. I was speaking to a group of ladies as well, ministers' wives, and I was saying to them, start having exercise sessions on the, they have the Mothers' Union on Thursdays and all that. I said, buy weights so that after you have the prayer session, it's well and good to pray and to seek God and to be in the Bible. But more importantly is to also practice things that will make your life to be better. So buy weights, and after that home cell or after the Thursday meeting, call one of your sons. And boys love to show off the knowledge that they have. I know I have a teenage son, so they love to show off what they've, what new skill, what new way, he's got muscles. So call one of your sons, they rotate. Every Thursday, one of the boys will come and teach you and take you on a class. You do muscle training. And you do it in a group, so it feels good, it feels nice as well. And you see yourself progressing from lifting a 1 kilogram, because that's where you're gonna start. You lift 1 kilogram, the following week 2.5, 5 kilo. Before you know it, you're lifting 10, you're like, who, me? Yes, you. You know, because your body has the capacity for that. The more you strengthen your muscle, the more your bones are going to be kept as well. The more your joints are going to feel better. One of the symptoms that I had was a hip, left hip joint pain. And I did x-rays and it said mild arthritis. I thought, my word, not me. So I started to have intentional ways of rehabilitating, physiotherapy, and just making sure that I do. And since I've been intentional about that, I haven't felt that pain since I was intentional. So it was a mild osteoarthritis. Obviously, you need to do it according to what your body can take, and also you need to consult with your doctor. But we encourage strength training for women, women of any age, but it's more important once we get to the postmenopausal stage. It keeps us, actually. And also, some studies have shown that when you do strength training, you do the muscle bulking, there are factors that are released in your brain that will help you even with your memory to prevent dementia, to prevent Alzheimer's. So you want to be doing strength training. Just do something that will help you guys as, you know, a group. Because if you have these avenues that you're doing here in general, I know this church is always, you know, it's always got programs running. So I don't know if you have like any exercise program or anything like that, but I think if you don't, it's a good time to start it. And start with the group that is not, that maybe people will not think you're gonna start it with the postmenopausal group. I think that will just be, you know, putting a twist to it, and it just makes it all the more fun as well. The other thing that you can do to improve your life is supplements. Taking omegas. Some patients who are in the perimenopausal stage, whenever, like, I recommend start your omega-3. That's the one that you need, omega-3. When they start omega-3, they find hot flushes actually improve. Some, it just disappears completely. Even your memory improves as well. And generally, it helps your cells to function better at a cellular level. So everything just feels better. Your heart, your joints, it's better. So that's omega. Calcium supplementation. Any woman of reproductive age should be on a calcium supplementation anyway, because of the type of lifestyle that we live. You know, we need to ensure that our bones are getting enough. You know that menopause, actually, for some patients, they say for about 30% of women, it will present with them losing a tooth. And you don't think it's menopause? Hey? Yes. And you won't relate it to menopause, but it actually is possibly, you know, the reason why, because your estrogen is important even for your calcium. And once it goes low, then your bones, and part of your bones is the dental structure. Okay? So it's important for us to be on calcium supplementation. Vitamin D also, that's one of the things I almost do routinely now with my patients, because most of us have jobs that keep us in offices and we don't go out in the sun. And then we find that there's a lot of patients who have vitamin D deficiency. And vitamin D, I had that. So yeah. My vitamin D levels were like 8. That's like, I mean, I haven't seen a patient, I think I actually have seen one that was lower than me. That's very low. And I was just feeling, it won't give you like specific symptoms. You'll have like non-specific things, like you're just tired, you just don't want to wake up, you just want to sleep the whole time. You're just not okay, but you can't say why you're not feeling okay. And for people who are in the reproductive age, it can even affect their fertility, because it affects cellular function. So I always say, let's correct the little things first and see how your body feels after. Magnesium also will help you. It will even help you to sleep better at night, so take magnesium at night. Yeah, so those are the supplements. Once you get really good with your supplements, creatine also is one that helps. It helps with your muscle as well to strengthen your muscles, like I've already said, that helps with your general body and also your brain. And then what else can you do? You can also go on hormone therapy, menopause hormone therapy. So before we used to call it hormone replacement therapy, but now the teaching is we call it menopause hormone treatment because it's treatment. It's not really replacing because it's a different type of estrogen that we're giving you than what the body manufactures itself. So there's different types of menopause hormone therapy as well. It just depends, and there's no like one size fits all. Medicine in general, there's no one size fits all. It just depends on your situation, whether you still have a uterus or not, your symptoms, and just your likes as well. But there's different types of hormone therapy that we have available. They can come in the form of creams, which we use vaginally. So people who are experiencing vaginal dryness, and that's all the symptom they're experiencing, you can only be on a vaginal cream. You don't need to be on the systemic treatment. And then the other systemic treatment for patients who have hot flushes and the night sweats, urogenital symptoms, so where they have urinary incontinence, like you laughing and you feel your bladder do a laugh of itself as well down there. Yeah. So for that, we can either start with a cream, and if that doesn't help, then we move on to systemic therapy. And like I said, that comes in the form of, it can be tablets, it can be patches, it can be pellets as well. There's vaginal rings. Yeah, it's just different, and there's gels that you can also apply. It depends on what it is that your body needs at that time. And it depends on your risk factors as well, what we put you on, and we just work your treatment according to what your symptoms are. So there's no one size fits all. I always find that my menopause patients, when those are the longest consultations because there's so many things to consider. It won't be, half an hour is never enough for us to make all the considerations. And sometimes I'll split it to 2 consultations where we're doing just the assessment and bloods, and then we come back again to now come up with a treatment plan specific for the patient. The other hormone treatment that you may need is testosterone. Okay? Like I said, we don't talk about testosterone enough as something that we need as women, but we actually do need it. So one of the other symptoms that I experienced was when I didn't feel like exercising. That was a symptom for me because I've been exercising all my life and I love exercising. So when I don't feel like exercising, I know that there's something wrong. When my libido, my sexual appetite just like down. And like I was blessed that I never really had libido issues. Of course it would be cyclical with the cycle, like I explained, when your estrogen levels are low, that can also go down. But in general, that was never trouble for me. So when I experienced those 2 things, that's one of the things I knew that, something is really wrong, something is up here. And I knew that I needed to attend to it. And once I started to attend to it in the form of treatment, I felt the difference. Like I was a runner. My last race was pre-COVID, by the way. So I stopped running completely, but now I'm back, because I'm on treatment. So sometimes when your body needs treatment, and the sooner you start the treatment, the better your response will be. So the symptoms that we will look at that need you to start hormone therapy will be hot flushes and urogenital symptoms when you are having urinary incontinence or the dryness, and so those are the main symptoms that we will use to know that this patient needs to be on hormone therapy, and then we put you on that. So we won't use it as much as the treatment will also help to protect the heart, to protect the bones, but we won't use it because of with the mild arthritis, I won't put a patient on treatment because she's got an arthritis. We need to attend to that and we need to supplement. But if they also have like a family history of osteoporosis and we do the bone density scan and we find that, okay, there is loss, then that patient needs hormone therapy. You know what I mean? So it just depends on every situation what it is that a patient will need. The other thing that helps also is community. Having a belonging, having somewhere where you feel I belong. So this, what you're doing, is community. Bringing women together, that's community. Where they feel I have an avenue. But I'd like to just add something. Okay, the singing, you do the singing. You worship, you do all that, because that's also what will help people to experience menopause better, when you sing. The play is the one thing that we need to also focus on and add. Play. It helps you to experience life differently when you are playing. Helps you to bring your joy back, you know. So whatever type of play, and I mean just like community play, I don't mean that other play. We'll talk about the other play. I'm just talking about play in general, just having that playful, you know, like we used to in our churches have plays. You know the church plays where one is playing, she's Maria, she's Joseph, and you know, that's play. So have whatever type of play that you can have that's relevant to your context, but just play. Play with your children, play with your grandchildren. Go out in the sun and just play with them. That releases the good stuff in your body as well, and you just laugh at yourself. You laugh at what you're limited in doing, maybe, compared to before. Just laugh at yourself, you know, laughter. So those are the three things I just wanted to remind you of in the community parts, that it's so important to sing, to laugh, and to play. It keeps you just as a human being, but even more so in menopause. We don't want to be the angry, grumpy grannies. We don't want to be those grannies. We want to be happy grannies that our kids... I hear a bravo there. Yes. We want to be happy, happy women. And the last bit that I want to talk about is just a reminder that that sex is good, even at our age. Thank you. I love, thank you. You are just the best. You're keeping me going here. So for most of us, I know in our African context, when I first had my period, the talk I had from my mom was, now that you're at this stage, don't talk to boys, because you're gonna fall pregnant if you start talking to boys. And I mean, obviously, I was smart enough, I knew that that's not true, but I mean, okay, I'm supposed to just say, yes, mom, you know. And I did say, yes, mom, and yeah, I didn't stop talking to boys because, I mean, my study partner was Tandegushe, a boy who knows maths, and I learn by studying with him, I become better at maths. So, but whenever she's asking me, you're still not talking to boys? I'm still not talking to boys, because that's what she wants to hear. So that's our introduction to any sexual experience, that it's something not to have. Even when I was going to varsity, the talk was, no boys, you're not gonna... So for us, it wasn't even as explicit. I don't know, maybe for some people it was. It was not, you're not gonna have sex. It's like, no boys, like, don't come near a boy. Let alone now, you know, talking to that. That's our introduction. And I always say that sometimes I think when I treat patients who have infertility, it's because their understanding of sex is that it's something not to have. So on a subconscious level, it's like they are not giving themselves fully to the experience, because That's what we have been taught. Because sometimes you look for a cause, you can't find it. Even with me, actually. For 5 years, I was trying to fall pregnant and nothing. And now my mom wants to ask me if, I was like, no, we're not going to have that conversation now. I think we should have had it back then, not now. Like, she wants to know now. I mean, are you and Mkwanyana, are you, are you, yeah. I'm like, I don't want to talk to you about that because it wasn't normal to us. Do you know what I mean? Whereas my daughter, our conversation is different. She's going to varsity, she's in matric, going to varsity next year. And I was saying to her, and I'm not encouraging her to have sex or anything, but I also know what happens in varsities. I treat varsity students, so I know what happens in varsities. So I'm like, hon, we need to start talking about contraception for you. And my daughter's like, Mom, I haven't even had my first kiss, and you're talking about, you think I'm going to have sex? I'm like, no, I don't think you're going to have sex. I'm not encouraging you to have sex, but I want us to be ready for anything, for life. And I want us to be proactive, you know. And also, I'm just opening the door for her to have the conversation with me when she's ready, you know. So I believe that that is how sex should be viewed, as something normal. And we've got scriptures to prove that, you know, because, I mean, I understand we're in church, so we must have the backing from the very book that we read in church, that sex is good, so that we all walk out of here and we know that our husbands are getting some. So I always say, for starters, if Sarah was still not having sex with Abraham, they wouldn't have had their son. And she was postmenopausal. So that's the first biblical example and the first sign that sex is good, even when you're in menopause. I compiled others, but now I don't even have my reading glasses. I can't see. But there's different verses that talk to us about sex being a good thing. The Songs of Solomon, you know, it tells us about the sexual experience as a positive experience. And yes, some people will not have their introduction as a positive experience like that because of, unfortunately, the horrible things that happen in the world. But we can certainly turn it around. Which other book talks about sex? Oh, it's the one that says, where Paul says, widows can choose to stay alone and not married. But if they find they're burning in lust and whatever, then they should get married. Meaning they have, yes, sex. So it's not something that we should be ashamed of, or we should keep as something that is unholy. Or, I mean, if there was no sex, we would not be here. So it is something that is actually approved by God, and we should introduce it to our generation, our children, as such, as something that's good and something that's beautiful. Of course, it has to be done in the right context, in the right way, and all. No, there's no right way, but I'm just saying in the, you know what I mean? We should allow them to view it positively, as a positive experience that it actually is. I'll send you the other verses that I had prepared that just show that it is good. So women should not be, when they get to menopause, think that this is it, no more for me. There are other avenues that we can still help with. I mentioned the vaginal cream, which is a hormonal cream. So if you're experiencing dryness, obviously your sexual experience is going to be painful because it's dry, right? And the body runs away from anything that's painful. So you're going to feel like it's a libido reduction, whereas it's just the experience is painful, so your body is saying, I don't want this, you know. So there are avenues that we can help so that your life is better. And with that, I thank you.
Can I just ask some questions?
Yes.
If you have paternal and maternal very bad cancer history, okay, grandmothers-in-law, the old way of thinking was no hormonal treatment whatsoever. Mother with breast cancer, sister with breast cancer, grandmother, great-grandmother, on both sides, no hormonal treatment whatsoever. Does this still remain?
Okay. So, yes, hormone therapy does increase the risk of breast cancer, but it's to someone who has an existing risk already. So it's not that everyone who's put on hormone therapy, their risk increases, but it's the one who has a genetic predisposition anyway, right? The risk, however, there was a study that was done that just escalated and made it seem worse than what it actually is, right? And that is how doctors were like, we're not putting anyone on hormone therapy because there's no doctor who wants a patient to have cancer on their watch. But later studies showed that the risk of having breast cancer from hormone therapy is not any higher than the risk that comes with obesity, than the risk that comes with increased alcohol intake and smoking. It's just a similar type of risk that you will have, which means that if also we are attending to your screening before we put you on the treatment and we continue to do the screening, then we should be able to pick up if there are changes earlier. There was something I wanted to say now. Slipped my mind.
Okay, so then the next question is, the person goes through, is premenopausal, not a hassle. Period, 6 months later, period, then they go. So now you're menopausal. Everything's fine, not a hot flush, nothing, no symptoms, just the end of periods. Then suddenly, 10 years later, now you're having night sweats, and is that all part of menopausal, or should you be looking further?
So, any patient who presents with menopausal symptoms, perimenopausal symptoms, we still have to look for other things that can feel similar to menopause. So we always have to exclude diabetes, we check for cholesterol, because even the changes, the hormonal changes themselves can also increase your insulin resistance and all that. So we still need to look for all of those things anyway, whether it presents at the time of around perimenopause, postmenopausal, or even 10 years postmenopausal. So we still have to do the baseline workup to exclude any other comorbidities. And also, yes?
So in other words, every year when you have your pap and your mammo and they're doing all the bloods and they're checking your sugars and they're checking your cholesterol, that's all part of checking it?
Yes, that is all part of the workup.
So if you're then having menopausal symptoms, like suddenly you have a night flush or you
a hot flash or night sweats.
Or night sweats, then, and you've ruled all that out, then you could just be having.
Yeah. So ovarian function is, as much as it will, your periods will stop at a certain age, there is some residual function that there still is in the ovaries. So that's why when we take patients, say you need a hysterectomy, you need to have your womb removed for whatever reason. Maybe you've got fibroids or you've got whatever issue, polyps that you have, and you need to have a hysterectomy. We will leave the ovaries if you haven't reached the age of menopause. Even if you're perimenopausal, we always advocate that let's leave the ovaries because they can still function for up to 5 years. The function may not result in a period, but it will protect your body from the other symptoms. So you may not experience those symptoms at that time, right? And if you experience them later, then we review and we may start you on treatment even at that time. Obviously, like I said, it's when you start the treatment early, then your body responds better. But if you didn't have symptoms, there was no need to, so there's nothing, that we can do. But the moment you have the symptoms and it's troubling you, then yes, we can start you on treatment.
And so once they use the wand and the ultrasound wand and they say your ovaries are shriveled, you know that's the end of it.
They're shriveled. So, everything sort of, the size goes down. So, because it's not as functional as it was before. So you will see the ovaries of a postmenopausal woman, the size itself, will be smaller. Was the follicles there, it looks smaller because that's the age you're at. Just like the muscles will atrophy as well. But you know that even with all the build-up and the diets that you choose, less sugar, all of that can improve and even improve how your ovaries function, which is how we are saying that it will improve your menopause experience. So you still won't have your period, but what the ovaries have been doing throughout their life, how they've been protecting your body, it can still have some residual function that will still protect your body.
So if you're doing ultramarathons and your diet is perfect, well, no diet's perfect, but
Yeah.
you know what I'm saying, and
Yes.
you're doing everything right, your menopausal experience will probably be good.
Yeah, probably. But there's still other familial factors that may affect it, but generally it will probably be good. It's a good prognosticating factor. Oh, the other thing I wanted to say was, for a patient who has that familial risk, if you can do genetic testing, for me, I always say, let's just do genetic testing and put it to rest. So we check for the BRCA genes and see if it's there or not, and then,
Sorry, Lungs, one more question. Oh, over there. I just wanted to know, if you've had endometriosis, okay, once you go into menopause, those cysts, do they scar, which then leads you to higher risk of cancer? Like if it's been on your bowel at the back of your uterus and now your uterus is dropped. And I know that one of the treatments for endometriosis is to stop the period, whatever.
Yes.
That's what they used to do in the old days. They used to put us on the pill non-stop for 6 months, no bleeding. But does it scar, and is that then a weakness where cancer could develop?
So it's what causes cancer is transformation. So the cells will undergo a transformation that can later then form a malignancy, malignant cells. Okay. So that's the risk factor. So that's why even with a pap smear, we're looking at the cells to see, is there any transformation in the cells that may end up causing a cancer? So even with endometriosis now, there's a lot of inflammation in the areas where they are. So I don't think I did define endometriosis, just to make sure we're all on this. Oh, you wanted to define that?
Not in details.
Yeah.
So that's what I was taking the mic for. But
Okay, go ahead.
So remember the initial picture that I showed you that inside the womb we've got the endometrial lining, which is shedding on a monthly basis. That lining contains endometrial cells. They're not meant to be anywhere else in the body, right? However, for some reason, there's many theories for it, then those cells find themselves outside the uterus, which will be either your fallopian tubes or your ovary or anywhere. Some people actually have it in the umbilicus. So those cells are not meant to be there, and they're endometriotic, which now, when you are having your periods, all those changes that Dr. Sibu was talking about, those cycling, right? So the endometrial part, those cells are also cycling. So that's why you actually have pain during the periods in other places, because those cells are sort of
responding to the hormones.
Yes.
Yeah.
Yes. So the cyst is okay. There's different types of cysts, but sometimes then you find that the cyst will have those endometriotic lesions, and they are either growing, that endometriotic cyst, where you find that if you have a cyst that's caused or has the endometrial deposits in it on a monthly basis when you are going on your periods, that endometrium that is shedding, remember this now, endometriotic cells are either in that ovarian cyst, they are bleeding. So that bleeding that is happening outside, going through the vagina, is not happening with that one because there's no way it comes out. And that bleeding goes into that cyst and it
area.
keeps on growing, and we call it chocolate cyst. It's meant to, it's a nice word, but it's basically the degradation of the blood. Remember, once blood has been there for a long time, it starts to change and it looks brown or dark. So those are the cysts, or I think that's the cyst that you're talking about. But basically, endometriosis is where you find cells, endometriotic cells outside the endometrium. They can be anywhere in the body or in the cavity of the...
So my question is, does that stay as scarring once you're menopausal or you're postmenopausal? And is there the chance that those could become cancerous? Because now you're saying unusual cells.
Yes. They're usual cells, but they're just in an unusual place.
Oh, so they're not prone to cancer.
They are. But during the time that you are still having your period, once you're postmenopausal, there is no hormone that will trigger it to respond like it was, during the time that you were having your cycle. So any cancer comes as a result of the cells in our bodies undergoing a transformation, a metaplasia, and then until it's a dysplasia. So that's to become abnormal. And once it's a dysplasia, then it's like a pre-malignant change. So those are the cells we look for with any type of cancer that we are trying to exclude. So with endometriosis, there's a lot of inflammation, and that's activity in the cells. And that activity can cause like metaplastic changes, which may later on become like dysplastic changes. And then once it's dysplastic, then that's a sign that it's likely to form a cancer. And that will only happen while you are still under hormonal control. Once there's no hormonal cyclical changes in your body, it won't respond as such. And it's said that about between 1 to 10% of patients who have specifically endometrial cysts, not just endometriosis, but endometrial cysts, do have an increased risk of getting ovarian cancer. And the transformation just comes from those changes.
Thank you, Dr. Sibu, for the presentation. My comment is on the very same menopause hormone treatment. And thank you for sort of de-animating this, because most women who are postmenopausal like myself, there's this debate and the discussion that we have even in offices, whether it's a yeah or nay, the thing of taking hormones, postmenopausal. Some of it is related to myths. Like it's taken as a, what can I say, as a factor that when you take hormone replacement therapy, you are predisposed to cancers, especially the breast cancer. So most women, postmenopausal, including myself, we battle with hot flashes. In summer, students are wondering what's happening to these women who are sweating like this in class. You understand? But this subject is quite important to me, because if I'm listening to you well, the message I'm getting is like the risks that you are scared of, they outweigh the benefits of menopause hormone treatment. So that is the first comment that I want to make. The second one is about supplementation for postmenopausal women. Now, you've listed the list of supplements, which I agree with you, because I just lost a friend who was postmenopausal and she had multiple fractures. Bones. She was just having osteoporosis and she was just breaking bones. And I could see that it's shortages of these calciums and what. Now, my concern with this one, you've mentioned about 4 or 5 supplements. Now, what would be your advice to women who are already on chronic treatment, taking X number of tablets for diabetes, for hypertension, and osteoarthritis? So this is in addition. Thank you, Doctor.
Yeah, unfortunately. But we also just take it according to what your body needs, because we want you to have a functional body. I want to have a functional body myself. So, and for patients who are skeptical about taking hormone treatment, I always say, let's walk. You know, I'm not here to force feed you what will work or what won't work, because your belief system will work with the medication. So my sister is not on treatment. She's sweating all over. And I always tell her, you're such a bad representation of someone who's a sister to a gynae, you know. But that's where she is. And I'll walk with her, you know, until every year, beginning of the year, she's like, okay, I think I'm going to go on hormone treatment this year. And I'm like, okay, come for consultation. And she'll come, consult, I'll script her, and then there's always a reason. I forgot, medical aid has run out, or this, but I can see she's not ready. And, you know, I try and educate her. She comes with me to most of my talks, so she understands everything, but she is not ready. And so you can't force a patient. That doesn't work. A person has to see it as something that they also need, and then they will take that step. So, but I always say, let's just start with the simple things that you don't have fear of. So the omega, because omega itself can even improve your high blood pressure, you know, and then you find that you have less of a burden of the antihypertensive medication. Then we can introduce other things as and when you need. There's also medications that have a package of all the supplements. Like my calcium, I take B-Cal K2 because it has all of those vitamins in one tablet. You know, because I don't also want to keep on remembering to take this and that and every other thing. I just take that B-Cal K2, and it's got vitamin B, it's got vitamin D, vitamin K, and the calcium that I need. And then at night, then I'll take the magnesium and the creatine, which helps with my muscle, strength. So you just work with what works with you as well. There's no like force feeding, so long as you understand and you make an informed decision on which choice of treatment you're gonna go with.
And I just want to say, please, ladies, cast your eyes left. There stands Auntie Ray. She's 92. Look at her.
I saw her. I kept on looking at her, tilling the So she's working. That's also strength training in a way. Yeah? Yeah. And that feeds her soul as well. Yes, ma'am.
Sorry, that said there's a high link between cholesterol lowering medicine and dementia.
Cholesterol lowering
medicine and dementia.
Okay, I'm not familiar with that. I don't know if Pam, you want to? I'm not familiar with that. I'm so sorry. I can't comment on that because I don't know.
No, and unfortunately, I don't think we both have experience of that. We don't really use those often. But I think, I already declared to them before we started that we didn't get 100% at school.
Yes, so it must be that lecture we had switched off. You know? Yes, ma'am.
Thanks. I just want to appreciate, firstly, the informative session that we're having. And then I wanted to just check, you've told a story about our lives, I think individually, but in a different, positive way as well. Mentally, I think it changes a person, but also I think how you carry yourself in line with your purpose in life and the things that you do, most of the things, they start with you as a person. So I do feel that there is a lack in the message, which then sees itself in a lot of other things that we are seeing in the society today. So you mentioned specifically with men. I do feel that there is a bit of emphasis, which is good, on women, and I do feel that in terms of being empowered, we are far better than they are. And I just wanted to check if there are avenues where they can plug in or where we can encourage that men or even boys, as they grow, they plug in. I have 2 sons, and I would like them to really change their perspective in understanding themselves better. Hopefully then it bears very good results for themselves as individuals in terms of their own paths in life. Thank you.
No, thank you. Thank you for that appreciation first. Thank you so much. So I always say it starts with us as well in our homes. What we teach, I've got 2 girls and a boy. The boy is the last one, and I must say, even in my parenting, girls for me, easy peasy, you know. But for the son, maybe because I come from a family of 3 girls, I'm the last one of 3 girls, and so my first sort of exposure to, I've got cousins and all that, but my intimate exposure was with my son, and sometimes I do feel like I struggle a bit with, imparting things to him. When I compare it with the girls, it's so much more easier with the girls than it is with him, but I still am intentional about just my message being practical on a day-to-day level. So not complicating it and making it big things, you know. You just start talking about simple things, you know. And I think that will make a difference if we just, in our communities. And yes, there are doctors, like at the Menopause Summit, I decided this year, let me have a doctor who does men's health as well. Because while we're looking at our menopause, what's happening to the guys? What is happening in their bodies is andropause as well. So there's stuff going on in their bodies while we are also, you know, going through our own menopause. And it's nice to help each other understand where we are, you know, so that we work better as couples, and we also teach the male counterparts what is going on. I think it starts with us. So there are, in fact, Thursday, I had a couple come, and the lady was saying that she came to the Menopause Summit and her husband was there. He wanted to come in with her. She had to stop him because she told him that it's a women's event. And I actually started thinking, probably we need a session that's going to be for couples as well, where we deal with, so which is what I think you are also confirming, that, you know, there is a need for that as well, where we just come as couples and we talk about our experiences, and, you know, we learn together and grow together. Yeah.
I think more so as well, because men generally are not outspoken. So it would be good if in their conservativeness they are informed.
Yeah. Yeah, no, definitely.
Sorry. Look, I mean, we are here. We are women in the church. I think we pose not a challenge, but to the authority, people in authority, that whenever there's meetings like this, I mean, men meet for different things. Just squeeze a little bit of a health talk, you know. I mean, and it can be anyone. It can be a woman. Once men are together and you are talking to them, they actually talk and they reveal lots of things. And one of the things I actually, because of time, I was going to touch on was prostate cancer. You know, men, there's so many men living with prostate cancer, and they're in their own isolated areas because they don't talk. So I think I'm glad as the church we are moving away from just preaching the gospel only, but not putting the practical day to day. So whenever you have meetings, I mean, even if you take 10 minutes to just touch on one topic, you know, that affects men, I mean, that's how we are actually introducing these talks. And recently I did a talk with couples, and it was daunting for me initially because I usually speak to women and find it easy, but it was actually interesting how engaging, and the men were actually the one who were asking more questions. So let's open those opportunities more.
Thank you. Oh, sorry. Yes, thanks very much. This has been really, really informative. And
I just see like a lot on social media that a lot of women land up in emergency rooms because they think they're dying, and a lot of those symptoms are menopausal symptoms. And we don't even know, some of them are just like so random. And what I'm saying is, a lot of times you're not, yes, okay, no, you're not having a heart attack. But the consideration that it could be menopausal is not actually, you're not encouraged to go and see a gynae, or, you know, it's just like, no, your heart's fine. You just, you know, so that kind of thing is. And then you tend to go to social media because you're looking for answers. And yeah, it's not always great, but sometimes you do actually find, especially if it's a group of women, that they'll say, oh no, I had those, you should go see your doctor about A, B, or C. So we need to, how do we judge that this is good advice or this is terrible advice? And what should we do when we know there's something wrong? I'm here, and okay, it isn't what we thought it was, but what, you know, how do we advocate for ourselves to get, I want to get to the bottom of it.
So I think the first thing, let me disclose, I am an Instagram doctor. I do have an Instagram page where I teach women, and I just talk about different issues that affect women, obviously medical, you know. So it came from that gap of seeing a lot of information being thrown around in the social media space, and sometimes, you know, you feel that, okay, this, I see what this person is trying to say, but maybe, you know, they don't really have all the knowledge or whatever, but then that's when I started my social media space where I talk about women, and obviously I've had training, this is something I do every day, so you look at the credibility of the source as well. So if you are looking into like social media, any of the Instagram, Facebook or whatever, so you look at who is giving the advice or the information and what training do they have in that space. Women's groups are also good because people share advice, but not everything will be applicable to you because you are a different person. You are you, you've got your own set of risk factors, your own set of, you know, issues. So it's important to know your own self first. And Dr. Google is not a great source because Dr. Google, you'll ask them, I have a pimple or a lesion on my skin, and they will give you everything from nothing to cancer. Yes, and obviously your mind will focus on the negative as well. You will hang on to the negative more than you do to the nothing, because obviously the fact that you Googled, you're thinking it's something, you know. So, and also thinking you have cancer doesn't help you. So going to a healthcare provider to address the issue, whatever it is what's going to help you, and then you have a diagnosis. When you come, we will also say, okay, we're not sure, it's got features that are suggestive of that it's nothing or that it's something, but either way, we're going to take a biopsy so that we know what it actually is, and then you've got your help. So, yeah, and then reading as well, but also just make sure that it's a credible source that you are reading from. Yeah. All right, I think that's everything. Thank you.
Sorry, Sibu. We can tackle this one together. I think you had a question, I'm remembering now, that we didn't answer. So I think maybe repeat your question.
I think she has answered it indirectly somehow, because I was asking about, you know, in accepting or acknowledging the fact that most of our lives are no longer the same way we eat organic food and so what are the preventative measures that you can take? So you are seeing a lot of people talking to things like moringa powder for prevention, taking, or what's the one that's common now? For energy. I'm forgetting it, but I'll remember it is. No, I've forgotten it. But there are just so many things out there. So where do you go for credible source? I think you have just indicated, because I was saying there's a lot of information that's flying around. So you almost want to be safe. So in terms of cancer, if there is a reliable source to go to in terms of seeking information, where is that? And I think you then just alluded to it then in terms of the social media as a whole. Thanks.
I think it's wonderful that there's so many women going into gynecology. Many years ago, I had problems, erratic periods, and I was told, male doctor, when you have children, it'll come right. You know, and you realize now, if you had been sent to a gynecologist, things would have been completely different.
So the other thing that we must remember also is that medicine has changed. Medicine itself has changed. It's evolved, it's growing. So they probably also, that was the best they knew at that time. I'm not excusing, that, but probably that's what was best. Remember, women have not been studied until recently. Even in I don't like giving someone my back. So even in our physiology books, if you remember, it used to be like the standard person that they're talking about is a 70-kilogram man, because that's the person who's been studied, the 70-kilogram man. Forgetting that the influences, the hormonal influences of the 70-kilogram man are different to a 65-kilogram woman who at that time is having a peak of estrogen or the lowest level of estrogen and progesterone at that time. And also that our physiology changes throughout the cycle. That is why I'm saying, let us accept it when we're being told we are different people, because we showing up as different throughout the cycle, so that's where it came from. And it's only recently that women are actually being studied. And partly it's in protection of the fact that women can fall pregnant at any time. Women change, women can have a good mood now and they have a bad mood and decide, I don't want to be part of the study anymore, and just like leave you, So
we weren't sent to gynecologists. We just had a GP, who, knew the family, and that was it. And you accepted it,
Yeah, no, I think,
there's so much, how medicine is advanced, as you say. It's
outlooks.
Yeah, which is wonderful for young people coming up there, having all.
For me, it's just that you could go to a woman gynecologist and say, this is the problem. You say, oh, yeah, I know what you're talking about. You go to a man and he says, okay, well, let me just look it up. He has no clue what you've experienced. If it's not medical or surgical and in the textbooks, he has no clue. Sorry.
Dr. Sibu, you mentioned that you are Dr. Instagram.
yes.
Yeah. Now, I just want to challenge you. I'm taking from the question that Pomi has just asked, that there's so much information going on about the moringas, about the different mixture in the social media. In so much that some people desert their prescribed medication, ARVs for example, and they go for those mixtures, mixing this and this until the virus stands up again and the people die when they're trying to go back to treatment. So now that doctor is in the social media, Yeah, that's why I'm saying I'm challenging you to say it is a problem not only for HIV but for all other chronic diseases. She made a good example of moringas. There are people who do not cook without moringa in their rice, who drink moringa. You know, there's so much belief about moringa. We have students from Africa who, you know, they will actually eat it as leaves. You know, there's just so much. So I'm just putting that on your table, Doc, to say, I wonder if you can also, and I'm not saying complementary medicine is not working. Please don't get me correctly. I'm not opposing complementary medicine, but my concern is when people now start to drop their prescribed treatment and stick on these unproven therapies. Thank you.
No, thank you. I note that. Thank you. Well received.
Wasn't moringa originally brought out to feed children? Isn't it like a natural food that just boosts them?
Yeah. So, I mean, a lot of these supplements are basically from foods like natural herbs and all that, a lot of them. But sometimes the issue is that it's something that has not been studied, maybe, that you can't really reliably say that, you know.
I might have the wrong one, but because I'm in with children,
Yeah.
with children, up in Africa they were saying 1 teaspoon of moringa powder was
Yeah.
like all the protein and everything they needed.
Yeah.
And I'm
So,
saying it's curing everything.
so no, it's the problem is not the actual plant. So the problem will be because it's not been studied, we don't really have a dosage of when it's now become medicinal as opposed to getting it from the actual plant as a leaf. We don't know how much of it your body can take or what more can do. You know, we don't know. So it's not that the plant or where it's extracted from, because all medicine, yes, it's from plants, you know. It's just that what we prescribe is something that we can always go back to literature to say, okay, this study showed that if we use this antibiotic as a daily dose, that's all you need. If we give you 2 times a day, it doesn't make any difference, you just get more side effects. So let's keep it to once daily, you know, so that's the only difference.
Sorry, that supplement that you mentioned was a B?
B-Cal K2, the one I take, B-Cal K2. And I'm not affiliated with them, I don't have any shares, it just works well for me. And I like that it comes as one tablet that has, a lot of the stuff that you need. It's got calcium, it's got vitamin D, vitamin K, and a bit of magnesium as well. Yeah.
And then you just take calcium as an extra?
You can take the magnesium as an extra. Yes, and also depending on your other risk factors, Please do invite me when you have that gym class.
We've actually got not a gym class, it's an exercise class that happens here once a week. That's good.
Okay. I just want to thank Dr. Ntshangase Mpanza and Dr. Lubelwana for the informative session that we've just had, and also not being stingy about what you have learned and also experienced. I mean, I can imagine that a few of us will pay a fortune to actually get an insight of what you've just shared with us today. So for that, we pray for more blessings to be thrown to you, and for God also to be with you in your journeys that you are traveling, and to continue with the good work that you are doing throughout the communities. The session is recorded, but maybe just on a lighter note before I can invite Desiree, when I told my wife that I'm coming here today, I first showed her the poster, yes, and she said, oh, okay. And then I said to her, I'll be there. And she never responded. Then I reminded her a day after that, I'm going there. She said, are you sure? So, but in any case, I think I do have an answer now as to why she actually said so. So I would like to call Dr. Lubelwana and also Dr. Ntshangase in front. We've got a small token of appreciation on behalf of Agnes, under the leadership of our rector, Sibu Ngobo, who unfortunately is not here today, but I think he is here with us in spirit. If you don't mind, maybe just coming in front, just to be with Desiree. So a last round of applause again. Let us pray. Our Father in heaven, we give thanks for the food, for the mind, and the realities that we need to face and actions that we need to take. We have been educated to prioritize support to all those suffering and are in the space of cancer. And we ask you, Lord, to give us strength and extra knowledge to be able to achieve this. We pray that you bless everyone in this room, everyone joining us online, and we ask for your merciful protection as we go out to continue with our activities of the day. Some of us are going back to work, and some of us are going further to serve. We also ask for good health to all those listening online in various places. And most importantly, our Lord, we ask you to bless our speakers today. That's Dr. Nompumelelo Pamela Ntshangase and Dr. Lubelwana, for the gift of the Holy Spirit given to them to specialize on this critical disease. Shine your light on them as they continue with their work and that they are doing to contribute positively into the communities. We ask this in the blessing of our Lord Jesus Christ, our Lord, who reigns and lives with us all the time, one God, now and forever. Amen. So let us go in peace to love and to serve the Lord. Thank you very much.